All right, let's continue that SHA conversation that we're having with Dr. Brian Lishenga, the chairman, RUFA, Rural and Urban Private Hospitals Association of Kenya. Dr. Lishenga, thanks for making time and for staying with us. You had mentioned that your meeting bore no fruit, and at this point, it's cash or no service. But you had said that when you're willing to sit down with the government and have a plan, why didn't you table a plan that could have been adopted for the solution going forward?
No, Trevor, we actually tabled a plan, and just to make it clear, there is no single private hospital in Kenya that is closed. Even now, as we are speaking, private hospitals and faith-based hospitals are open. We are continuing to offer service.
Except it's in cash now.
Except that we cannot continue to extend credit to a creditor, a debtor that has proven that they cannot pay. So we have just put a pause on that, and we have been very clear in our communication that it is temporary, because we intend this to end very soon. We did put counter proposals. In fact, we have been proposing since the transition began that SHA should have adopted a first in, first out mechanism of settlement of claims. Right now, what SHA is doing, they have adopted a last in, first out. So every time you hear this narrative that we are paying SHA claims, they are actually paying last in, first out. But historical claims that are supposed to be settled are not being settled. The other argument that has been made is that money is money, for instance, that we can give you money now, you just count it as NHIF money regardless of where it has come from. We have an issue with this because there are service providers who are providing care right now under SHA. We have to pay them for the care they are providing, but they have not been paid in many hospitals for care they provided under NHIF. So you cannot basically shift that amount. Those services still need to be paid for. But Trevor, the point that we have made to the ministry consistently, that this is not about hospitals. This is not about hospitals. As you know, a lot of hospitals may adjust. And one of the things we fear about this course of action is that the state may become numb to the suffering of Kenyans and just say, let Kenyans continue paying anyway. And you understand that a lot of these providers may find a way to adjust, okay? So one of the ways is say we accept only other insurances, or maybe say we only accept cash payments. Businesses could adjust that way. The concern we have, because we have a relationship with these patients, and especially in rural areas, I'm thinking about where I come from, for instance, people in Kakamega, in Navaholo, in Lurambi. I have been to some of those villages, and I can tell you for sure, Trevor, that they cannot adjust. They are not able to adjust their pockets, and therefore, we have taken this action very painfully, and the reason is we have given the analogy of a patient who has a tumor. If you have a tumor or a mass that is growing, you have two options. You could let it grow and kill you, or you could go through fairly painful surgery and remove the mass and then have a very long productive life. So in our view, the action of demanding that healthcare is financed properly in Kenya is intended to cure long-term the problem of underfunding of healthcare. Just remember, Trevor, we signed the Abuja Declaration as a country. We are supposed to spend 15% of GDP by now on healthcare. We are spending about 4.6%, and if you look at what is happening on budgets, year in, year out, we are actually reducing funding to the Ministry of Health. To make it worse, with the changes that have happened with the USAID, in the US, the donors who are funding a huge chunk of our budget, that has been pulled out. So we are in a position as a country where we have to take bold decisions in terms of financing of healthcare. This is now fully our responsibility. But what we feel saddened about, because as providers, we are also slightly more informed than the normal Kenyan about what is going on. So what we feel saddened about is that the burden of financing healthcare in Kenya has been left to the common mwananchi. It is the common mwananchi now that is funding healthcare services. If you ask me, there are people who say that, Daktari, it can't be all bad. I went to a hospital and my bill for SHA was paid. I just wanted to correct that, because it is a very strange notion. It is not that your bill for the hospital was paid. It is that the hospital agreed to extend credit. You know,
so the money wasn't.
The money didn't arrive. So,
okay.
So people need to make a distinction. At the point where you say SHA paid for me, SHA didn't pay for you. What actually happened is that you went to a hospital, and a hospital extended credit to SHA because they believed that the contract would be honored. So we have not ceased services. We have just said that the creditor needs to behave themselves. And let me just make an extra point here, Trevor. Kenyan people have a contract with SHA. It might be unwritten, but part of the reason we fund SHA through our taxes and our contributions is that we have an unwritten contract that when I fall sick, you will stand by me. So there are two contracts we are talking about here. There's the contract between a Kenyan and SHA. And there's a contract between SHA and the provider. So one of the approaches we are taking, if you go to a hospital and you are SHA registered and you end up with a cash bill, ask that hospital to give you that invoice, walk to your nearest SHA office and tell them to reimburse you.
And claim it.
Claim it.
But Dr. Lishenga, you know, aren't you punishing the wrong people here? Because the patients have nothing to do with their accrued debts.
It's a very interesting question, Trevor. As I said, I gave you an analogy of a painful surgery, but I can extend this a little bit more. As it is today, the healthcare system is not functioning. The healthcare system is problematic. The vast majority of Kenyans who go to primary healthcare facilities, level 2 facilities, level 3 facilities, find either the hospitals are unequipped or when they need a lab test, they are actually asked to pay. When they need drugs, they are actually asked to go across the street. So Trevor, let's just be honest here. We have reached a point where we are saying we are naked. That is the point where we are. Even if we were to keep quiet, Kenyans will still continue suffering. So the point is we have come out in public now and with the interest of our patients, because we see them. Trevor, I should tell you that it's very difficult for a patient who is suffering and you are having a money conversation. We don't want to have money conversations with patients. I don't think healthcare providers want to have money conversations. They want to have treatment conversations with patients. But when you are in a situation where you are telling a patient, this care is expensive, your benefit package is very small, we cannot. I give you an example. When we were going through the public participation and trying to justify why Kenyans should pay more, remember we used to pay 500 shillings if you are an informal sector. And for people who are on salary, the maximum was 1,700. But we had to find a justification why Kenyans have to pay more, 2.75% if you are employed. And again, a lot of people who are now informal sector going through this thing called means testing. They are ending up with 1,000, 1,200, 2,000 shillings, 800 shillings, much higher premiums than they used to pay. Not only that, we now have a requirement that you have to pay 1 year in advance for those amounts of money. So what was the justification for the Kenyan people to pay more money? The justification was the benefit package would be better. Now, let me give you an example. When we went through the public participation, for example, on ICU, today you will ask me, you talk about the questions of Kenyans being punished. Kenyans are being punished already because if you end up in ICU, the maximum reimbursement you get per day is something in the region of 4,900. 4,900, an ICU admission per day, even if it was said there will be no margin, just cost only. Just cost, nothing being added, just you're counting syringes and needles, just cost is not going to be less than 200,000 per day. If you are reimbursing 4,000 shillings and yet a Kenyan is paying more, you are charging them more money. And we enriching SHA at the benefit of Kenyans. When we went through the public participation, the proposed reimbursement for ICU, which we also didn't like, by the way, we didn't agree with it, but it looked like an improvement, was 44,000 Kenya shillings per day. However, they had put a limit of 14 days. So it was coming up to, a limit of about 10 days. So it was coming about 450,000. We still told them, in most ICUs, 450,000 will be wiped off in 2 days. So we felt that this was still a small amount. But Trevor, still, 44,000 was much better than 4,000. So we were surprised when the cabinet secretary gazetted a tariff of 4,900 shillings per day for ICU. We saw proposals the other day to improve it to 28,000. 28,000 is still halfway of the worst position where we were. What we are saying is this: if the Kenyan people must pay more money by 2.75%, if they must pay more money by proxy means testing, the justification was the benefit package would be much better.
Okay.
We expect out-of-pocket payments to go lower and not to be in the situation where, you know, one of the promises is that this is the end of Harambes. No more Harambes, no more WhatsApp groups. We have costed healthcare, and I will tell you, they are very brilliant people at the Ministry of Health. They know the cost of treatment for malaria. They understand. They can even cost for you a room in a consultation room. How much is the rent per month? They have included it in. For instance, for malaria, it was very clear. Normal malaria, 530 something shillings. Now tell me, why did we end up with a gazette notice of 75 shillings per month or 900 per year? Healthcare is being deliberately underfunded. Okay. And we as a country have to take a decision on this.
So how long are you going to do this as we wind up on this conversation? Because you see, there seems to be a standoff between yourselves and the government.
So we think that this will not last too long. We don't think that the government will be so insensitive as to make this the status quo. And Trevor, I just want to mention that it is not private hospitals only. Public hospitals are struggling. And if today Kenyans go to public hospitals, they are experiencing shortages of drugs. They have never asked themselves, why do public hospitals not have drugs? It's the same problems we are experiencing. The only difference between these private and faith hospitals is we can speak up. And we can come out and say, hey, no. This was not the promise we gave to Kenyans, and you are exposing them. I think that the government will respond to the cries of Kenyans. And as I said, this is not about hospitals. Hospitals will adjust somehow. This is about Kenyan people.
Do you have another scheduled meeting?
Yeah, hopefully, there's no scheduled meeting for payments. There's a scheduled meeting on the outpatient reimbursement mechanism, which again, we have insisted is the wrong mechanism. Trevor, you know today that for you to get care in Kenya, you have to start at level 2 and 3 before you are referred to a level 4. When we went through public participation, the promise was that at level 4, you will be paid for to see a specialist. We are not going to refer. You don't get to see the same level of patient, of doctor at the lower level. And there was even a reimbursement mechanism. How many Kenyans are going to level 4 hospitals and they find a specialist who is covered by SHA? These are the things we are not agreeing to. We are saying, instead of painting hospitals as the bad guys, can you meet your side of the bargain so that we can provide the kind of care that we have promised to the Kenyan people? And we are afraid that this is endangering Kenyans, because when we have to cut the cost of everything so as we fit into the budget, what are we going to give patients?
Okay. Dr. Brian Lishenga, thanks for making time. The chairman of the RUFA, Rural and Urban Private Hospitals Association of Kenya. We'll see how it turns out once the meetings are done and see way forward. It's important to mention that we did invite the SHA officials. They didn't make it. They didn't have the latitude to come. All right? We're taking a quick break here. When we come back, there's still a lot more coming through on the Monday Report, so don't go too far.